Thank you, everyone, and welcome to this webinar on a very important topic. We'll be launching a supplement that is in BMC that is focused on STI point of care testing. My name is James Kiarie. I was involved in the early phases of this study with Dr. Igor Toskin, with who will be co-chairing the session. And I do not want to spend a lot of time because I know the reason most of you joined is actually to listen to the researchers and to hear the results of these studies, which I think are critical on how point of care testing will move forward. But I would just like to take a few moments to first acknowledge the people within WHO who have contributed. We'll have a chance to acknowledge the other contributors, but many times we forget those who have done all the heavy lifting in-house. I would like to acknowledge Karel Blondil, who did a lot of the heavy lifting work, working directly with the sites, Dr. Soso Twain, Ronaldo de Silva, and Kushet Nosiro, who supported the statistical analysis and data management of this work. And of course, my colleague, Dr. Igor Toskin, who ably led this study from WHO. And Natalie Ann Bailey, who has really worked very hard to support this webinar and has been together with our colleague Jane. I think together they've done a lot of work to have this webinar off the ground. And then also our assistant Natalie Mora, who is not here with us and has really provided fantastic administrative support. And as you'll hear that this study spanned several continents and many countries and many research sites. So it required quite a lot of administrative work from here in WHO. I would just like to say for us in WHO and also in HRP, STI is a high priority area. And for WHO, we have actually two departments that work on sexually transmissible infections. Our department, the SRH department, and also the HIV, hepatitis, and STI department. And it is critical that all policies, maybe the national policies or global policies, be based on the best available evidence and science. And this is actually at the core of WHO, and we have a science division that is led by a chief scientist, just really to lay prominence to the importance of research, the importance of evidence in all the decisions we make. And this study, what we'll be sharing today, will really provide important evidence that we hope can be able to inform norms and standards going forward in all matters related to point of care testing. So with that, those brief comments, our director, Dr. Pascal Alote, could not be with us today in person, but took the time to record a message, which we'll hear next.
Throughout the last decade, substantial research has been undertaken to develop and validate point-of-care tests, or POCTs, to diagnose sexually transmissible infections, STIs. The potential of STI POCTs to advance STI prevention, providing clients with targeted and essential STI services, would greatly support universal access to healthcare, an overarching goal of the World Health Organization. However, Further positioning, promotion, and use of the new technologies and approaches requires strategic thinking and planning in order to maximize their potential benefits and to reduce possible risks. Since 2018, the World Health Organization has been coordinating an independent multi-country, 15 countries over 30 sites, a clinical-based evaluation of STI point-of-care tests. More than 17,000 participants were enrolled over a period of 3.5 years, and the tests were performed by non-laboratory staff at testing sites in peripheral clinical settings. The findings of this study highlight that it is crucial to test the performance of these technologies in the field outside of controlled laboratory environments. These studies indicated that before the rollout of point-of-care tests at peripheral settings, it is essential to provide appropriate training, adequate supervision, and the institution of both quality control and external quality assessments. This would optimize the further introduction and scale up the use of these revolutionary technologies for maximum benefit of populations most in need, especially in countries where access to laboratory testing is limited.
Yeah, thank you so much, Pascal, for that message. And next, I'll call on my colleague, Dr. Igor Toskin, to introduce the session and the key highlights. Over to you, Igor.
Thank you very much, James. And I would like to welcome everyone who attended, who connected today to this webinar. And I'm very pleased to be with you today. My name is Igor Toskin. I work in the same department as James, Sexual and Reproductive Health and Research, World Health Organization, Geneva. And before giving a very quick overview of this project, PRoSPeRo project, I would like just to explain the modality of today's webinar. We will have a series of the formal presentations by the researchers representing country research team on the results of some studies, because it's a multi-country and also multi-arm study. And once we finish the formal presentations, we will open the floor for the questions and answers. So for you attendees, we would like to suggest that you raise your questions using the function in Zoom Q&A. So you can address these questions to the speaker. So if you have any general questions, please specify, and we will try to do our best to respond to your questions. We would like also to ask you to identify for the questions, mainly name, and if it's possible, preferably also institution that you represent or the institution where you work. Once again, thank you everyone for joining us today. And I'm going to a very quick presentation from my side. So again, it's a very, very quick overview of the PRoSPeRo project, which is an independent multi-country clinic-based and clinic utility evaluation of STI technology, STI diagnostics within context of point-of-care testing. STI epidemic remains very high across all WHO regions. According to the 2022 WHO global estimates of prevalence and incidence of STI, 374 million new cases of curable STIs, estimated mainly chlamydia, gonorrhea, syphilis, and trichomoniasis. WHO recognized the impact of STI on the global public health. In May 2022, the 75th World Health Assembly endorsed the health sector strategy for HIV, viral hepatitis, and STI. The main goal established for the STI and this strategy is to end STI epidemic through advancing universal health coverage, primary health care, particularly in terms of ensuring patient-centered, evidence-based, high-quality services for the people in need, This strategy recognized the importance of research and innovation. So the work that we are going to present to you today fits very well with the strategic direction number 1 and strategic direction number 5 of the strategy. Namely, strategic direction number 1 is deliver high quality evidence-based people-centered services, and direction number 5, foster innovations for impact, particularly the research that aim to support the implementation and maximum impact of the use of new intervention, new technologies. For several decades already, the point-of-care testing as approach has been recognized as an important element to improve STI control and prevention. We, WHO, for many decades, been working on the rapid diagnostic test, and particularly for the last probably 20 decades, where the paradigm shift on the shifted on the point-of-care test. For the last decade, we conducted several technical consultations, international consultations where the experts globally recognized international experts in the field of STI, control and prevention, epidemiologists, clinicians, laboratory experts, microbiologists participated. The main objective was really to identify the key areas of work on point-of-care test, STI diagnostics for WHO and the international STI expert community. One of the products of this work is a special issue that we published in 2017 in BMG STI journal. This issue comprises several systematic reviews, research articles, opinion articles as well. And one, it's an article that tried to identify again key areas of the work, what we call roadmap for advancing work on development and implementation point-of-care test. This roadmap consists of 13 key areas. And among those, experts participated in the consultation, and the authors of the paper stressed the importance of standardization of the diagnostic evaluation, including laboratory-based evaluation, clinic-based evaluation, and utility evaluation, in terms of having some kind of standardized protocol based on the best international practices for evaluation. Also identify key priority areas for evaluation as screening, particularly for asymptomatic infections, and case management. Also the priority populations where the point-of-care test can provide maximum benefits. And of course, the evaluation that aims to understand the analytical, clinical performance of the test, as well as operational characteristics and other statistical means that help to understand the utility of this test for the programs. So basing on this, WHO between 2006 and 2017, in collaboration with several technical partners, developed 9 core protocols to support exactly the strengthening of the evaluation of diagnostic test, point-of-care test. On this table, you see some kind of summary of key protocols that were developed: laboratory-based evaluation, particularly for evaluating diagnostic tests to detect Neisseria, gonorrhea, chlamydia, trachomatis, and Trichomonas vaginalis. A series of the protocol for clinic-based evaluation, including evaluation of rapid test for HIV, syphilis, dual HIV, syphilis, within context of the screening among pregnant women, key populations, men who have sex with men, and sex workers using whole blood as a sample. Also, protocols for evaluating tests for the screening of asymptomatic infections in women at high risk for Neisseria, gonorrhea, chlamydia, trachomatis, Trichomonas vaginalis, using vaginal cervical swabs. One protocol for the case management, assessing exactly the diagnostic test for same pathogens as for women at risk, but particularly within context of the women presenting vaginal discharge, as well as the screening for asymptomatic chlamydia, trachomatis, and Neisseria, gonorrhea infections. In extragenital infection among men who have sex with men, and one clinic utility protocol for assessing feasibility, acceptability, and operational characteristics of the dual HIV syphilis test, as a part of the community testing among men who have sex with men. All these protocols were rigorously reviewed by the WHO Technical Review Panel and Ethic Review Panel. And these protocols are fully available, accessible on our WHO website. Then, between 2018 and 2021 particularly, we established a global network of countries who participated in the implementation of the protocol that I described above. These protocol, of course, were adapted to the local context, local settings, and all these national specific protocols were also very carefully reviewed by WHO technical panel, ethic review committees, including technical panels and ethic review committees at national level before being implemented. This map represents the countries involved in the clinic-based evaluation of molecular-based technology, which we will present, the results of which we will present you later today, and lateral flow technology for HIV and syphilis. And in this study, as James already mentioned, 5 continents, 5 WHO regions participated. In Latin America, it's and WHO Office for Americas, it's Peru and Guatemala. For African region, it's South Africa, Uganda, and Zambia. For North African region, it's Morocco. For European countries, it's United Kingdom, Malta, and Italy. In Western Pacific region, China and Australia. Next slide presents the countries that participated in the clinic utility study. And this study was co-coordinated, co-implemented in collaboration with the Epidemiological Center of Spain in Catalonia. And the study was implemented in Ukraine, Slovenia, Latvia, and Spain, Catalonia. So the main purpose of the clinic-based evaluation in the countries that I mentioned above was assessing clinical performance of the test, sensitivity, specificity, predictive values, likelihood ratio, and some operational characteristics. And the clinic utility study, it's mainly assessing feasibility, acceptability within context of the community-based testing. At the end of my presentation, I would like to acknowledge everyone who contributed, who participated in this study. The list is very long, and I wish to pronounce each name in my acknowledgement, but probably it will take several minutes, if not longer. And I would like to start just with the acknowledgement to all ministries of health and health authorities from all 15 countries supporting this study, principal investigators and members of research team also from all 15 countries, from Australia, from Guatemala, Italy, Latvia, Malta, Morocco, Peru, Slovenia, South Africa, Spain, the People's Republic of China, the United Kingdom, Uganda, Ukraine, and Zambia. I would like also to thank our technical partners who provided outstanding technical support for the implementation of the study. WHO Collaborating Center at the CDC Atlanta, led by Dr. Elena Kirsch. WHO Collaborating Center at the University of Verona, led by Professor Massimo Mirandola. Now the Collaborating Center at the London School of Hygiene and Tropical Medicine, led by Professor Rosanna Pilling at that time. Our Collaborating Center at the Flinders University, led by Professor Mark Shepard, and the WHO Collaborating Center at the Örebro University, Sweden, led by Professor Magnus Unema, who participated in our webinar today as well, and many colleagues I listed participating in our webinar today as well. Also, manufacturers provided the test in kind either for evaluation or for reference testing about diagnostics, chem biodiagnostics, Cepheid, Hologic, and CQC diagnostics. I would like acknowledge the guest editors, supplement editors who help us to develop the publications, articles, and support the peer review of these articles, Professor Ron Ballard and Professor David Lewis, as well as the BMC editors, Ms. Abiola Lawal and Mr. Omar El Bakri. And of course, I would like to echo the acknowledgement that already James said to all WHO colleagues who provided outstanding contribution and support to this study. Very quick information about supplement. Unfortunately, the COVID-19 pandemic affected the implementation of the study in some countries. The study completed in all countries. Today, we are going to present you some results of some studies, but the current supplement includes more articles, and you will see this QR code that we can use to access the supplement articles. And we expect that the 3 remaining articles that are not yet published will be released by mid-2024. And we will inform you on the release of this article. So by this time, the full supplement will be made available. And I would like to thank you once again for your attention and for your participation in this webinar. So we can move to next presentation, probably.
Yes, thank you, Igor, for that overview, and also for acknowledging the outstanding support that this study has received from so many researchers and collaborators. So our first presentation is by Nigel Sherif from the University of Brighton in the UK. Over to you, Nigel.
Thank you very much for the introduction, and good afternoon. So today I'm going to talk about the clinic-based evaluation of 2 dual POCTs for the screening of HIV and syphilis amongst men who have sex with men in Italy, Malta, Peru, and the UK that we undertook as part of this global PRoSPeRo project. The evaluation design was based on a WHO standardized master protocol for a prospective cross-sectional multi-center clinic-based evaluation of dual HIV syphilis POCTs for screening amongst MSM, sex workers, and pregnant women. So this is the master protocol that was independently peer-reviewed and approved by the Research Project Review Panel, RP2, of the WHO, and by the Ethics Review Committee, ERC, of WHO. It was then adapted to the 4 individual countries participating, and then also reviewed and approved again by those same panels, as well as the respective institutional review boards at each site. So the approvals for this were incredibly thorough and extensive. This particular protocol focused on MSM, who one of the WHO defined key populations in terms of being one of the groups most in need of increased access to STI prevention, testing and treatment. In terms of process, interested potential evaluation sites from around the world could apply to join this network through an open call. The applications were assessed on a range of requirements like technical capability and proficiency of the local laboratory, but also the point of care site capacity at the local clinic. So for instance, the number of patients coming through the door. And the University of Brighton, where I'm based, as well as our clinical partner, the Sexual Health and Contraceptive Service, or SHAC, also based in Brighton, then joined the network in early 2018. So the primary objectives of this evaluation were twofold. It was firstly to assess the performance of 2 dual point of care index tests, namely the SD Bioline and the Chembio dual path platform, the DPP. So both of these use finger prick capillary whole blood and then compare that to the gold standard referenced lab-based serum tests, so namely HIV ELISAs and then a treponema reference test for syphilis. A further primary objective was also to assess the minimal operational characteristics and the acceptability of these index tests for both healthcare providers, HCPs, and users. So for instance, for patients, looking at the amount of time they'd be willing to wait for their result, their preference over a single or a dual test. And for the healthcare provider, things like the clarity of the kit instructions, training time required, ease of use, and so on. There was a secondary objective of the study, which I'm not going to be able to cover in this presentation, but it is discussed in our article on this protocol, which is published today in the BMC Infectious Diseases special supplement. The link is at the end of this talk. And that was to explore the performance and the potential utility of these point of care tests in identifying probable active syphilis using a combination of treponemal and non-treponemal tests as a comparator. So as mentioned already, the tests evaluated with the SD Bioline Duo test and the Chembio dual path platform. Both of these are single-use qualitative immunochromatographic assays or lateral flow tests. The Chembio company also developed a microreader, which you can see here in the image at the bottom right. developed to minimize potential error due to subjective visual interpretation of the test. The microreader is essentially just a portable battery-powered reader with a little LCD, a liquid crystal display, that fits on the top of the POCT using a dedicated holder. And that display then shows the status of the instrument and the test result to the operator. In terms of the sites for this protocol, 4 countries participated with 7 recruiting sites. So just over 2,500 clients were enrolled between May 2018 and October 2020. The sample sizes were calculated based on the estimated performance of the POCTs and the seroprevalence of HIV and syphilis amongst MSM locally. In each site, the results from the tests, including from the microreader, were then compared with the reference tests. So for HIV, these were lab-based 4th generation ELISAs confirmed by Western blot, so antibody only, or equivalent. And then for syphilis, the reference test was the TPPA, the treponema pallidum passive particle agglutination, or the equivalent such as TPHA. External quality assessment, or EQA, for both the reference laboratories using proficiency panels and POCT sites using dry tube specimens were supported by the CDC in the US. And there's also QC, quality control procedures, in place for sites at weekly intervals, whereby the local lab prepared known sera for staff to use on the POCTs. So to be eligible to participate, the clients needed to be 18 years or older, be in attendance routinely at one of the sexual health clinics at the study sites, have not previously participated and been able to provide written informed consent. Really briefly on enrolment, each participant was assigned a unique study ID number, which is delinked from any personal identifiers. The HCP, the healthcare provider, would then use a standardized paper-based structured questionnaire, or CRF, case report form to collect client information on demographics, medical history, acceptability regarding the 2 index tests. We then collected 2 types of samples, so the venipuncture blood for serum collection and later reference testing, and then capillary blood collection by finger prick method using the 2 POCT devices. For the POCT results, we used a double reader method, which is where the readers were both independent and blind to each other. And they were either doctors or nurses in the clinical setting who'd been trained specifically in the study's procedures, including specimen collection and reading in accordance with the manufacturer's instructions. And then following specimen collection, the HCP administered the second part of the questionnaire to the client, and then standard care procedures were followed at that point. You can get all the details of the procedures in the already published protocol paper, which is open access in the BMJ. As you'd probably expect in this key population, pooled data from all sites showed that there was a very high proportion of MSM who reported having tested previously. On the left there, you can see that around 84% had previously tested for syphilis, and roughly a third had reported a previous syphilis diagnosis before the study enrollment. For HIV, 94% reported having previously tested, and around 20% reported a previous diagnosis prior to enrollment in the study. Based on the reference testing algorithm, then nearly a quarter of all the participants were confirmed HIV positive, so 23%, and just over 1/3 were positive on the treponemal reference testing. So of all those participants showing evidence of antibodies to T. pallidum, about half of those were found to also be reactive on RPR. And of those who were HIV positive, around 60% also had evidence of antibodies to T. pallidum. And amongst these, 60% exhibited reactive RPR, indicating probable current infection and co-infection. So if we look now then at the performance of these POCTs for the HIV component compared to the reference assays, overall both Bioline and ChemBio performed well, with similar performance in terms of high sensitivities and specificities across all sites. The pool sensitivities was above 98% for Bioline, ChemBio, and the microreader. The pooled specificities were all over 99%, and the agreement of the results as read by the 2 readers was very high, so about 0.98, so almost perfect. You can see here for the Peru site that the specificity of the HIV component for Bioline was a little bit lower than the other sites, with an unexpectedly high number of false positives, around 9 compared to the reference test. We're not sure exactly the reason for this, but we don't think it was a technical issue, as other sites in Peru use the same batch of tests. Probably not a systematic reader issue either, given that 3 of the false positives were not confirmed by the independent second reader, and the first reader for these cases was not always the same. It is possible that these MSM may have participated in an HIV vaccine trial that was running at the same time in Lima, but we can't be totally sure. But nevertheless, when pooled, you can see the performance of the HIV component of these tests appears to be acceptable. If we look now then at the treponema components of these index tests compared to the reference testing, sensitivity of both these tests were, as expected, lower than for the HIV component, but still with very high specificity. So looking at the pool data, the sensitivities were, as you can see on the left there, 73% for Bioline, 78% for Chembio, and 80% for the microreader. And the specificities were all over 99%. And again, when we looked at the agreement of results as read by the two readers, the kappa was high and significant at 0.97. So again, almost perfect. What you may see here, though, of course, is that the sensitivity for the UK site was low for both index tests. So 47% for Bioline, 55% for Chembio, and 59% for the Chembio microreader. So for Bioline in particular, that does mean that over 1/2 of the UK cases with proven prior exposure, namely a positive TPA result, were undetected. So Chembio performed, as you can see, marginally better, but for the UK site, still failed to detect just under 1/2 of all the UK proven positives. Now, again, we don't think this was a systematic error in sample processing because the laboratories demonstrated very high external quality assessment performance. Both the POCTs gave expected EQA results at the site level using the dry tube specimens and weekly quality control checks, which were done after every 20 tests or so, or weekly, suggesting therefore that the HCP operating procedures was also probably not a factor. But something that could have been at play here is that during the study period, PrEP was available in the UK clinical site as part of a national research trial at the time. And as HIV PrEP users probably expose themselves more frequently to the risk of STI acquisition, and given the Brighton site has a very comprehensive STI screening program, so every 3 months that's required as a result of PrEP uptake, any individuals are treated almost immediately, which potentially could compromise the magnitude of the antibody response, which of course would impact on the sensitivity of the test. In terms of acceptability, perhaps unsurprisingly, most participants prefer to have one dual test for HIV, syphilis, and infection rather than 2 single tests. Almost all were willing to wait for the results of this kind of test if this technology became available in their clinic in the future. And of those who were willing to wait, over 90% reported they'd be willing to wait for at least 20 minutes and up to 2 hours for their results. As these test results are available within 15 minutes, this of course provides quite an important opportunity for immediate referral into treatment. Clinic staff from across the different sites completed a short questionnaire on the dual test's operational characteristics. Things like clarity of the kit instructions of easy use were reportedly very clear or excellent for around 70% of providers for Bioline, a little bit lower for Chembio to around 50 to 60%. Ease of interpretation of these tests was reported to be 100% for both POCTs. And most providers reported these test results were indeed available in 30 minutes or less, with a hands-on time of about 5 minutes or less. And for training time in order to actually perform these tests in accordance with the manufacturer's instructions, all providers reported needing less than an hour for Bioline, and around a quarter needed just a little more than an hour for the Chembio. The strength of our study here was the enrolment of a very large sample of MSM, including a sizable proportion of positive cases, as well as generating point of care test evaluation data from multiple centres and settings using standardised WHO core protocols. The pooled results do suggest that Bioline and Chembio dual POCT for HIV and syphilis had acceptable performance in terms of the HIV component, but lower performance for the syphilis component. The POCTs were acceptable to MSM and with operational characteristics that were acceptable to the healthcare providers. So with the probable exception of the syphilis component for the UK, this kind of dual point of care technology could be considered as potential alternatives to the standard methods of screenings, not only in clinics, potentially reducing waiting time and loss to follow-up, for example, with patients not waiting for the results, but also outside of clinical settings where venipuncture may either not be safe or settings where laboratory testing may be challenging. So that just leaves me to say thank you to the University of Brighton study team, which includes our clinical partners at the Shack, and a huge thanks to the WHO core team, including the wider PRoSPeRo network. Thank you.
Thank you very much indeed, Nigel, for your presentation. And as I mentioned, we will keep our questions till the end of the webinar. And now I would like to invite our next speaker, Dr. Wei-Ping Medlin from the CDC Atlanta. And Wei-Ping will present the results of the quality control and external quality assessment component introduced in the arm that aim to evaluate lateral flow technology for HIV and syphilis. Wei-Ping, the floor is yours.
Thank you, Igor. Can you see my slides?
Very well.
Thank you. Good morning and good afternoon, everybody. Today, I will share a study of the external quality assessment to support WHO PRoSPeRo study for the evaluation of the two dual point of care HIV syphilis tests in 7 countries. So before I start, I would like to thank everyone involved in this study, including staff from Division of STD Prevention and Global HIV TB at the CDC. WHO, we're also part of WHO Collaboration Center for STI Prevention, also staff from WHO and also international collaborators. I know the list here didn't include everybody collaborated from WHO in the 7 countries. Some of them not listed here. Thank you everybody for your hard work. So as we know that syphilis and HIV contribute to the major global public health issues, syphilis globally has an estimated 7.1 million adults between 15 to 49 years old acquired syphilis in 2020. Also, more than 600,000 infants with congenital syphilis in 2016. And also congenital syphilis is the second leading cause for preventable stillbirth globally. Here's some data for the 2022 HIV. About 1.3 million people acquired HIV in 2022, and where women and girls account for 46% of the new infections in 2022, including 1.2 million of pregnant women. More than about 130,000 children also acquired HIV in 2022. So the key for prevention is screening for the key population and also early accurate diagnosis, which is important to provide the correct treatment and also control the spread of STI. So 2014, WHO called for elimination of mother-to-child transmission of HIV, syphilis, and later this effort was expanded to address the vertical transmission of hepatitis B virus infection. Essential triple EMTCT service also emphasized that the importance of testing for STI infections in prenatal care, and also the importance for prominent effective treatment for the women who test positive. So sensitive diagnostic tests include NET, the nucleic acid amplification test has been advanced in the past years, also improved STI diagnosis. However, they are high cost and they require certain lab infrastructure, also usually have long turnaround time. So all these factors actually limit accessibility, and particularly in low and middle income countries. And POCT, point of care tests, which are affordable, sensitive, rapid, equipment-free, and also accessible to the end user are promising tools to combat the rising rate of STI. The rapid dual HIV syphilis test was recommended by WHO as a first-line test for pregnant women attending the prenatal care, and also WHO published 2 different articles to emphasize the point of care test. As for CDC, we have STI treatment guideline also provide guidelines of POCT, the POCT test for different STI as a cost-effective strategy against the STI infection. CDC also recently published the lab recommendations for syphilis infections, also include information for 2 FDA-cleared point-of-care tests for detection of T-peptide antibodies, and emphasize that an accurate point-of-care test, the serology test for syphilis, could shorten the time to treatment. To ensure the quality of STI testing in the front line and in also the clinical lab all over the world, CDC, in collaboration with WHO, has this WHO CDC syphilis serology proficiency program. And this program will provide proficiency panel, 5 vials for each panel, to all over the country, national reference labs 3 times a year. The lab will perform testing, use whatever technique they use in the lab, and they generate reports, submit the report electronically to CDC, and the CDC will create a report and share the results, and also willing to provide technical support for whoever the lab needs support. As Nico mentioned, that in this study, 2 rapid tests were included: HIV syphilis test from CanBio, DPP, HIV syphilis, and also the SD BioLine. The CanBio DPP was approved by FDA in 2020, and also this is the first dual rapid test approved in USA. And this test was intended to use a microreader shown in this picture. The visual interpretation could be very subjective, and the reader is required to use a test. The SD BioLine is the WHO pre-qualified dual rapid test. Our study is part of the PRoSPeRo study, aimed to assess the need for EQA, the external quality assessment, for this dual rapid test in different national laboratories and also their clinical sites in 7 countries. So in this study, the panel will prepare in CDC. We have 2 different panels. We have the liquid panel with the 5 vials. We also have the dry tube specimen panels, and all the panels will ship to a national lab, and the lab will further distribute the DTS panel towards the clinical sites. And after testing, all the reports come back to CDC, and we will create a report and share the results. So first, for the national lab testing, we use the liquid panel. The HIV syphilis reactive or non-reactive serial samples were purchased from commercial sources and further tested at CDC. And 5 panels were prepared in CDC, adequate to different vials, sealed and labeled and shipped to the lab. So each panel, we have 5 serum specimens contain 1 syphilis reactive only samples, 1 HIV reactive only, 1 reactive for both syphilis and HIV, 1 non-reactive for both syphilis and HIV, and 1 biological false positive syphilis series, which is non-treponema test reactive, but treponema test non-reactive. So the QC panel was tested in CDC before ship out the different labs, and the data was summarized in this table. Sample A was HIV reactive, and the tests conducted in CDC include syphilis testing, treponema TBPA, non-treponema RPR, and also 3 different tests for HIV. So the sample A1 was HIV reactive, A2 was HIV non-reactive, but reactive for treponema antibodies, and the RPR was also reactive. We also have titer RPR 1 to 2. Sample A3 was a negative control, no reactive, no detective antibody to both HIV and syphilis. Sample A4 was reactive both HIV and syphilis with RPR titer 1 to 1. Sample A5 is a biological false positive, which is only reactive to non-treponema tests. So from 2018 to 2022, 7 labs in 7 countries. Nico mentioned before, all the involved countries participate in this study. So 4 out of the 7 labs complete all 3 rounds of testing, and lab 1 was only complete 1 round, while lab 6, 7 didn't complete any round because they already participate in international EQA programs. So over 15 rounds of testing was expected, and there's only 13 rounds complete, with the participation rate is 68.7. The number of clinical sites received in each country vary from 1 to 4. A round of testing with 3 testers per site were expected from each clinical site. However, the actual number varies from site to site. About 0 to 8 rounds of testing was conducted. 10 out of 14 sites performed at least 1 round of testing. That's about 7.71%. A total of 15 rounds of testing were performed on all sites, and we totally received 140 reports. So each round of testing was assigned a maximum score of 100. So we have 5 specimens. Each specimen is 20 points, so total will be 100, and the passing score is 80. So for HIV and syphilis qualitative tests, an incorrect result is score 0. For quantitative tests, if your titer is within 1-fold, below or above, that's about 20, that's 20 points. If it's 2 dilution or 2-fold above or below, that's 20%, 20 points. If you 4-fold above or below, that's 10 points. If you above the 4-fold or 2 dilution, that's 0 points. So here's a table lists all the scores for each lab and for each round of testing. So all labs score above 100 for each test round, which result in a 100% pass rate. So we also look at the performance for each test type in the lab. So lab test result detect for HIV and the T pattern antibody were compared to the results obtained in CDC lab, STD lab. The overall agreement for qualitative RPR test was 95.4, which suggests very good agreement. For RPR quantitative testing, about total 8 discounted results were observed in the lab, and which all had a titer above 4-fold higher than the CDC test results. The overall agreement is 87.7%. For qualitative TBPA, it's 100% agreement. For quantitative TBPA, there's 14 discounted results, which end up in 82.5 agreement. For qualitative HIV tests, 4 samples gave discounted results, which result in a 93.8% agreement. So as I mentioned before, that the clinical site use the DTS. DTS method was published before. It's a very efficient, affordable method for the EQA program. And for this specimen preparation, we did the same as before, has a liquid panel. We'll then further mix the liquid panel with a food coloring dye and take 20 microliter out to each tube, let them dry overnight, sealed and labeled, and sent to the national lab, and from there distribute to the clinical site. So there's also 5 panels included, 5 samples include each panel. Here the table shows the score for each test run in the clinical POC site. So the score is a little bit complicated. Each test has a 4 result, and each result we score them, and total would be 20 points for each specimen, and the 5 specimen each panel end up in 100 score point. So here the data shows that total 10 sites will perform total 50 rounds of testing with a passing rate of 94.3%. Each round testing, they have different scores. Some of them pass, majority of them pass, some fail. The average score is 94.3. We also zoom in to look at the test performance for each test, and this table shows the test performance for detection of T-pattern antibody at a POCT site. So this result again compared with the CDC result, and overall the POCT site achieved 94.4 and 94.1 agreement for the DPP and the SD bioline testing. 8 out of 10 POC site has a percent agreement above 95.8, which is pretty good. And site 3, there were 10 and 12 false negative syphilis results as compared with CDC results using the DPP or using the SD bioline. Test site 10 has 19 false negative results among the DPP tests, and also around SD bioline, they have 18 false negative results as compared to the CDC result for the detection of a T-pattern antibody. We also look at the HIV test results for the detection of HIV antibody in all sites. Most test results from DPP and SD bioline were consistent with the CDC results, and which has a 98.7% and 99.1% agreement as compared to CDC results. So in summary, with the global burden of HIV syphilis, especially among pregnant women and key population, point-of-care tests allow rapid detection with linkage to treatment. Overall, the reference lab participate from this program from 7 countries perform very well. All passed the EQA syphilis and HIV testing. Both HIV syphilis POCT gave expected result from the clinical test sites, and DTS, the dry tube specimen, has been proved to be a useful tool and a robust tool to monitor the quality of POC testing. However, we did find some sites has a less satisfactory performance, especially site 3 and 10. So the quality testing vary at the laboratory sites and suggesting the necessity for a quality assurance program for the point-of-care testing. So that's all for my presentation. Thank you all. I will take questions at the end of all the presentations.
Yeah, thank you, Wei-Ping, for the presentation. And our next presenter is Maddalena Codioli from the University of Verona in Italy. And over to you, Maddalena.
Thank you so much, James. Let me share my screen. Can you see my screen now? Okay.
Yes,
So,
yes.
Thank you. So, good afternoon, dear colleagues. It's a pleasure for me being here to give you this brief talk on the main findings of the clinic-based evaluation of CT&G point-of-care tests for the screening of genital and exogenital chlamydial and gonococcal infections amongst men who have sex with men. The main objective of the study was the assessment of the performance in terms of characteristics and usability of the expert CT&G assay for CT and NG screening at genital and exogenital sites among MSM compared to gold standard laboratory-based nucleic acid amplification tests. In the robust methodology and the detailed procedure of the study will be soon made available on the BMJ Open Journal, whereas the detailed description of the finding I'm going to talk to you briefly is already available on the BMC Infectious Diseases journal. Briefly, this is a multi-site international study carried out in 4 HIV STI sexual health clinics in Italy, Malta, and Peru between February 2018 and February 2021. As Igor said earlier, COVID-19 pandemic required us to stop the enrollment for a 2 years long period. In terms of methodology, each consecutive MSM presenting at the above-mentioned clinics were asked to join the study after the signing of the informed consent. Participants were in addition asked to be 18 years old or older and reporting having had sex with at least another man in the previous 12 months. Each participant received an automatically generated unique code bar to participate in the study anonymously and to be able to withdraw his laboratory test results. And for each participant, we collected 3 different specimens typed: urine, a genital site, oropharyngeal swabs collected by the trained healthcare staff at the clinic, and anorectal swabs self-collected by study participants according to the clinic's gold standard practice. In addition, a structured questionnaire as per WHO core protocol was used to collect demographic and behavioral characteristics of study participants, as well as their HIV STIs previous history and the acceptability of their point-of-care test approach. At the clinics, a proper amount of urine and 1 swab per anatomical site randomly selected was used to perform the CT&G point-of-care test, whereas the remaining biological specimens were sent to the lab for the laboratory tests. As soon as the index test provided its result, it was recorded by the healthcare staff on proper form for each anatomical site. And in case of errors or invalid results, the point of care test was repeated if the specimens left over was sufficient. Treatment was provided only according to laboratory-based tests following international and national guidelines. The study enrolled 1,702 MSM across all sites with a median age of 32 years old. As you may see here, almost 2/3 of study participants reported a previous STI diagnosis that in almost 1/3 of patients where it was syphilis. 1/5 of study participants were HIV positive, and 20% reported a previous gonorrheal infection, whereas 15% reported a previous chlamydial infections. Study participants provided us with 5,049 biological samples, of which 5,035 were available at the clinics to be tested with the point-of-care test. Only 24 point-of-care test results were excluded from analysis due to error or invalid results, and it has to be noticed that the vast majority of the latter were from anorectal samples and none from urine. A meta-analysis of diagnostic tests was used to analyze the results, aggregating data from the 4 participating sites. A random effect bivariate model with logit transformation was used to estimate pooled sensitivity, specificity, positive and negative predictive values, as well as likelihood ratio. This table shows the analytical characteristics of the CT&G point-of-care test in both overall and in each specific geographical site, considering different anatomical sites. As you may see here, specificity was found to be almost perfect, both overall and in each study site for both gonorrhea and chlamydia, whereas sensitivity varied largely across different anatomical sites for both pathogens. Here we may see that the sensitivity of the point-of-care test for gonorrhea at the genital site, it means using urine, was found to be slightly above 90%. That is pretty much in line with that described by Guy and colleagues in 2017 in their meta-analysis of the same point-of-care test. The sensitivity at the genital site for the chlamydial component found in our study was lower than expected, as you may see here, 84.82%. In this case, more than 10 percentage points lower than that described by Kelly and colleagues in their meta-analysis. As for the exogenital site, starting from the rectal one, the sensitivity for the gonococcal component in our study resulted slightly lower than 90%, whereas for the chlamydial component, we found a sensitivity lower than 80%. Comparing our results with those already available in the literature, there are only 2 studies that assess the CT&G point-of-care test performance at the anorectal site. The first was published by Goldenberg and colleagues in 2012, whereas the second was published by Badman in 2019. Although both studies collected rectal swabs from STI clinics attendees, the Goldenberg one, and people at risk for STI, the Badman study, respectively in London and in Papua New Guinea, the point-of-care tests in both studies were performed at the lab. And in terms of comparison, our results resulted pretty much in line with those described by Goldenberg for both gonorrhea and chlamydia, whereas they differ a lot from those surprisingly high described by Badman for both CT and NG. As for the pharynx, this was the site in which our index test struggled the most in terms of sensitivity for both NG, as you may see here, 75.87%, and even more for the chlamydial component, 67.79%. As far as we know, there is just one paper published by Bristol and colleagues in 2019 evaluating the performance of the NG-CT point-of-care test at the pharynx. And in the meta-analysis they conducted using a Bayesian approach, Bristol and colleagues found a positive % agreement pretty in line with the one that we found for both NG and CT. However, as clinicians, we need to go beyond the technical characteristics of the test, namely sensitivity and specificity, adding other information to our global evaluation that are namely the likelihood ratio of the test and the prevalence of the infection in that specific anatomical site and in that population. And bearing this in mind, we described the prevalence of the gonococcal and chlamydial infection in our population as that found by the reference test result of the study. As you may see here, the Neisseria gonorrhoeae prevalence at the genital side was found to be 2.1%, 6.7% at the pharyngeal site, and 7.5% at the rectal site. As for the chlamydial infection, we found a prevalence of 3.2% on urine, 2.7% on pharyngeal swab, and 11.2% at rectal site. However, in order to assess the clinical utility of our index test, we decided to describe 4 different prevalence scenarios using the minimum and the maximum real-life prevalence found at the clinics enrolled in the study, and describing 2 more scenarios, adding and subtracting 5% to these prevalences. And the final output of the clinical utility approach can be described by the Fagan's nomograms. In this graph, you may see 3 vertical lines. The y-axis on the left represent the pre-test probability, namely the prevalence of the infection in that anatomical site, in that country for that specific population. The central vertical line is the likelihood ratio of the test in that specific anatomical site. And the final output is the post-test probability represented by the blue line, the positive one on the y-axis on the right, and the negative post-test probability represented by the red lines. And bearing this in mind, having our target of 90% positive predictive value, we found that at the pharynx, the site where our index test struggled the most in terms of sensitivity, with a sensitivity of 75.9%, only considering the real-life highest prevalence plus 5%, we reached our 90% positive predictive values for chlamydia. Whereas for the gonococcal, instead for the chlamydial component, where in terms of sensitivity, we found a 67.8%, even when the lowest real-life prevalence is considered, we reach our 90% positive predictive value. As for the rectal site, for the gonococcal component of the index test, we reached our target when the lowest real-life prevalence was considered, whereas for the chlamydial component, the target was reached considering the highest real-life prevalence found in the study. As for the genital site, using the biological specimen for which the CT-NG point of care test was initially conceived, for both NG and CT, despite the differences in sensitivity, the 90% positive predictive values was reached when the highest real-life prevalence was considered. And the same was for the CT at genital site. In conclusion, the assay showed optimal specificity regardless of the type of infection and anatomical site. Our findings showed very good negative likelihood ratios and confirmed the use of CT and G point of care tests to rule out further assessment in the case of a negative result, regardless of the prevalence of infection. Sensitivity varied across sites and pathogens, with the highest agreement with the reference tests reached on urine for NG and the lowest on pharynx for the chlamydial component. Considering the high acceptability of the CT-NG point of care test by our target population, it could be a strategic tool for implementing testing frequency and reaching those not yet tested in both traditional and unconventional testing venues. The use of STI point of care tests in non-laboratory settings and by non-laboratory staff has to be conceived in the context of a cyclic training and quality monitoring program with the aim of guaranteeing the optimal quality standard required for all diagnostic tests. I would now like to thank all the colleagues of the PRoSPeRo network, the healthcare staff at the clinics, the study participants, and you for their attention. Thank you.
Madalena, thank you very much for very clear and comprehensive presentation. And now we are moving to our next speaker, Professor Mark Shepard from the Flinders University WHO Collaborating Center for STI point of care test. And Mark will present the results of the clinic-based evaluation of molecular-based test within context of screening for asymptomatic infections among women at risk. Mark, please.
Thank you very much, Igor. Is everybody able to see the screen?
Very well, Mark. Thanks.
Thank you. So, thank you, Igor. So it's gleaned really from the title of my talk. I'm going to be covering two aspects of the PRoSPeRo study. Firstly, the evaluation of point-of-care tests for chlamydia, gonorrhea and trichomoniasis for screening women at risk in 4 countries, South Africa, Guatemala, Morocco and Australia. And secondly, I'll be providing some brief commentary on the development and implementation of a quality management system providing QC and EQA testing for STI testing in the broader PRoSPeRo study across 8 countries, which include the 4 countries in the Women at Risk study, but also China, Italy, Malta, and Peru. So if we look firstly at the Women at Risk study, in terms of the point-of-care testing clinics involved, in South Africa, testing was conducted at a youth clinic near Cape Town, in Guatemala at an STI clinic in a regional-based hospital, and in Morocco at a centre for free and voluntary HIV and STI testing near Rabat. And these countries performed clinic-based point-of-care testing for all 3 pathogens, CT, NG and TV. Australia performed point-of-care testing for TV only. 3 Australian sites were initially engaged, but because of workflow issues at 2 of the services, the study was completed largely by 1 remote Indigenous health clinic off the north coast of the Northern Territory. In terms of the patient cohort tested, women aged 18 years or over were defined at risk for STIs if they'd reported unprotected sexual intercourse with more than 1 partner in the last 12 months, or they'd had a past history of STIs, or they were women performing sex work, or were Australian Indigenous women living in remote Aboriginal communities. So prior to having the point-of-care test performed and following their informed consent, each participant was assigned a unique project ID number They undertook a pre-test questionnaire comprising 14 questions delivered by the clinic nurse, and their responses were transcribed onto individual de-identified case report forms, or CRFs. 2 vaginal swab samples were then taken from each patient, either self-collected or clinician-collected, and there was no order specified for the vaginal swab collection with regard to their allocation for either gene expert or laboratory testing. So as previously described and shown on the right-hand slide of this slide, the point-of-care testing clinics in the study used the Gene Expert system from Cepheid to test for CT, NG and TV. For the reference laboratory testing, samples from Guatemala and Morocco were sent to the WHO Collaborating Centre for Gonorrhea and other STIs in Sweden for testing on the Hologic Panther device. And samples from South Africa were analysed at an in-country reference laboratory also using the Hologic Panther. In Australia, TV samples were analysed by a reference laboratory in Western Australia, which used both the Cobas 4800 device and the Hologic Panther during the study. In terms of training resources provided, our Flinders International Centre for Point of Care Testing developed a training package for the STI component of the study. The training package included a PowerPoint presentation on the Gene Expert system, including basic operation, how to conduct a patient QC and EQA test, and interpretation of test results, and a series of step-by-step posters, as well as short YouTube videos visually summarise the performance and reporting of the patient QC and EQA tests. And I've just shown some selected examples of the resources on this slide. In terms of the delivery of training, operator training was generally delivered through face-to-face sessions conducted on-site in the participating countries, but there were some local differences in terms of the health professional status of the operators trained, the duration of training, the health professional status of the personnel delivering training, and whether translation of the resources was required or not. So in terms of data handling, in each country, the Gene Expert result from the device was manually transcribed onto the CRF form by the site operator. And the result on the CRF form was then entered into the WHO's Open Clinica data management system by the site organiser. In Australia and South Africa, results from what's called the GXX file, which is a Gene Expert specific DX software file format from the Gene Expert laptop, was also cross-checked against the results recorded on the CRF. And test results were reported as either positive, that is detected, negative, not detected, or invalid, error, or no result. And the latter 3 result options indicated that the test was unsuccessful and the Gene Expert did not produce a valid test result. Samples that were initially reported as unsuccessful were repeated if sample volume allowed, and if a valid result was obtained on repeat, then this result was reported for the patient. And at the completion of the study, the data analysis was performed by the WHO statistical team, and clean results were sent to our international centre for us to facilitate the write-up of the study. So just looking at some of the results, in terms of prevalence, based on the results of the reference laboratory NAT testing, the overall prevalence of CT, NG and TV in the women at risk populations surveyed were 31%, 13% and 23% respectively, with a range of prevalences reported between the 4 countries being quite variable. Also, co-infection rates were highest for the combination of CT and NG. Just looking now at the method comparison, in total there were over 1,250 valid or paired test results for CT and NG, and just over 1,330 valid and paired results for the TV test available for subsequent concordance analysis between the point of care and the laboratory methods. And the sensitivity and specificity estimates, both pooled and within country, are shown on this slide. So if we look firstly at the right-hand column of the table, you can see that the reported specificity for both within and between countries was excellent, greater than equal to 97% for CT and greater than 99% for NG and TV, with narrow confidence intervals for all three tests. But if we look at the left-hand side of the sensitivity column, we can see that the pooled estimates of sensitivity were 83.7% for CT, 90.5% for NG, and 64.7% for TV. These estimates also varied considerably between countries. So if we look at the right-hand side of this particular column, we can see for sensitivity, for example, sensitivity as low as 70% was reported in Morocco, and for TV, sensitivities of 59.7% and 66.1% were reported in Morocco and South Africa, respectively. We also looked at positive and negative likelihood ratios, and in general, likelihood ratios of greater than 10 or less than 0.1 are generally considered to provide strong evidence to either rule in or rule out disease diagnoses. And so for CT, the ratios were 37.7 and 0.17 respectively. For NG, they were 95 and 0.1, and for TV, 56.5 and 0.35. And just a further note, the rate of unsuccessful tests was very low on the gene expert, or less than 2%. So poor sensitivity observed, particularly for TV, was certainly an unexpected finding and not necessarily consistent with results published by other groups. And in Australia, our centre, in combination with the Kirby Institute at the University of New South Wales, manages a large point-of-care network for STI testing on the gene expert for the Australian government. And there are 65 Aboriginal medical services in this network, and concordance that we see with parallel laboratory test results in this program is very high, greater than 98% for all three tests, including TV. So we don't have a definitive answer to account for the poor or variable sensitivity, but possible explanations could include perhaps the differences in the training system employed in the different countries, as previously described, may have contributed. There may have been degradation or instability with samples transported to the reference laboratory, but if this was the case, then intuitively you'd expect that the point-of-care positive samples would be reported as negative by the lab, but in fact the reverse was found. There may be differences in detection limits for the gene expert point-of-care device versus the Hologic Panther device used by the reference laboratories, and that could have been a contributing factor. And also potentially manual transcription errors might have occurred when transcribing the results from the gene expert to the CRF, and these may have been partly responsible for the poor sensitivity, as these weren't cross-checked via extraction of GXX files in 2 of the countries. So just in conclusion, looking at the results of the Women at Risk study, this multi-country evaluation of point-of-care testing for STIs is the first of its kind in the world. The gene expert point-of-care test results were clinically acceptable for ruling in the presence of infection based on the sensitivity and positive likelihood ratio estimates, whereas the gene expert point-of-care testing results were poorer than expected for ruling out these infections, particularly for TV, based on variable sensitivity and negative likelihood ratio estimates. So I'd just like to conclude by briefly commenting on the quality management component of this study. So along with the development of the training resources, our International Centre for Point-of-Care Testing at Flinders was responsible for the delivery of a quality management system for all the PRoSPeRo studies involving STI point-of-care testing. Quality control and external quality assessment samples were provided by the National Serology Reference Laboratory Australia, or NRL, which is an accredited global quality assurance provider and WHO collaborating centre. So for QC testing, that was available to all 14 point-of-care clinics across the 8 countries involved. And for EQA testing, it was available to point-of-care testing clinics and reference laboratories supporting each clinic, except China, which used its own in-house EQA material. The composition of the materials prepared by NRL is shown in this table. So the QC samples consisted of CT-NG duo and TV-only swab samples, and participating point-of-care clinics were provided with a set of 15 swabs that were either CT positive, NG positive, and TV negative, called QC1, and 15 swabs that were CT negative, NG negative, and TV positive, QC2. The EQA samples consisted of any combination of the 5 manufactured samples, and for EQA testing, each participating clinic, point-of-care clinic, and reference laboratory were provided with initially 2 sets of 5 swab samples at the start of the study, so-called Set A and Set B. So looking at the QC and EQA results overall, those specifically returned from the point-of-care testing clinics, combining the data for the 2 quality control samples provided, the overall concordance with expected results was 100% for chlamydia, 99% for NG, and 96.8% for TV, while the rate of unsuccessful test was 3.7% for CT and NG, but was 18% for TV, with the majority of those unsuccessful TV tests being reported as an invalid result, 70%. Combining the data for the EQA results returned for Set A at the point-of-care testing clinics, the overall concordance with the expected results was 97% for CT, 100% for NG, and 94% for TV, while the rate of unsuccessful tests was just 5% for CT and NG, but a disappointing 66% for TV on initial testing, with again the majority of unsuccessful tests being categorised as invalid. So in conclusion, quality management should be an integral and mandatory component of any point-of-care testing system. The quality materials that were produced for the STI component of the PRoSPeRo program were satisfactory for CT and NG, but they showed poor performance for TV on the GeneXpert system. Again, we don't have a definitive answer as to the high rate of unsuccessful tests observed, particularly for TV, but potentially reasons to explain this finding might be that the TV is a protozoan species rather than of bacterial origin, like CT and NG. Perhaps the concentration of human cells provided as baseline in the EQA samples was approaching the detection limit for the internal, what's called a sample adequacy check on the GeneXpert. And perhaps additional stabilizers could have been added to the prepared material to prevent degradation of human cells. So in conclusion, the WHO should continue to work with industry and EQA providers to try to provide improved materials that are reliable, stable, and cost-effective for quality management as it seeks to roll out molecular-based point-of-care testing in non-laboratory settings. And as for other speakers, I'd certainly like to acknowledge the large team of people who were involved in this research, particularly Igor Toscan and Carol Blondil from the WHO management team, and especially acknowledge Dr. Susan Matthews and Kelly Andrewartha from our Flinders International Centre for Point-of-Care Testing, who had significant impacts into the delivery of the program and the paper write-up, as well as all of the principal investigators and co-authors from the 2 arms of the study, the Women at Risk study and the QC EQA study. So thank you very much, Igor.
Yeah, thank you very much, Mark, for that very nice presentation. Our last presenter for this webinar is Professor Ron Ballard, who is a consultant in the Department of Sexual Reproductive Health and Research in WHO Geneva, Switzerland. So over to you, Ron.
I am sorry, I have lost a button, which is crazy.
Well, it happens.
I can't find the advanced button. It's gone.
Yeah, we don't see your slides.
I know, because I haven't been able to select them yet.
Okay.
So screen, advanced,
Ron, if you click on the share screen, green icon, you will see 3 options: advanced, basic.
I've done it.
Okay.
I click on advanced and it just doesn't do anything.
Okay. Would you like that I project your presentation? Probably
Yeah,
not the final.
that would be fine. Thank you.
Okay, my pleasure.
Thank you. Thanks
pleasure.
very much, Igor. I'm presenting this on behalf of my co-guest editor, Professor David Lewis, and myself. You'll understand that David actually played a major role especially in the last year, as a result of some problems that I had. Next slide, please. So unfortunately, I don't have any data to present to you. So I'm going to talk about the project itself again and highlight how different it is to normal evaluations. So we're evaluating point of care tests for STIs in primary health, primary care settings. These settings were in conventional clinics, and some other papers as well were in unconventional settings too. The testing was conducted by non-lab staff, as we've mentioned before, nurses and outreach workers, and the studies were conducted in resource-rich and resource-limited countries, in both urban and rural settings. And I think this is very, very important. The various populations and subgroups that were studied included both symptomatic and asymptomatic patients and subjects, and to cover both diagnostic and screening applications of these tests. And both genital and extragenital anatomical sites have been sampled, and of course, and that's with the gene expert. Standardized laboratory-based gold standard testing was performed for comparison, and special training, quality control, and external quality assessments were in fact provided too. Next slide, please. So generally, the performance of POC showed poorer sensitivity, but good specificity when compared to gold standard lab tests. And of course, the lateral flow tests showed poorer sensitivity than the amplified platform. The sensitivity of POCs was lower, particularly when asymptomatic individuals were screened, and an emphasis should be placed on training of both laboratory staff to do the gold standard tests. Often these are tests that they're not doing routinely, and healthcare workers at sites where POC tests are being evaluated. The sites where POC evaluations are undertaken should participate in both an external quality assessment program for labs and be able to create internal quality specimens for use at peripheral sites. So it's very important that if we continue to do these evaluations, that these EQA and QC pieces are actually put in place. There's a need for all study staff to fully understand the need for attention to detail, completion of documentation, and further training to accommodate any staff turnover. Staff turnover is often very high, especially in rural areas where staff may well be rotated around various sites. And of course, one should remember that these staff are not used to doing research, and therefore the attention to detail and the completion of documentation is absolutely vital. Next slide, please. So WHO and partners should continue to facilitate and lobby for the development of new reassured POC diagnostics, particularly those that can be deployed in resource-limited settings. Tests should initially be evaluated in reference laboratories, as has happened in the past. And the problem is that you can actually gerrymander the rates, the specificity rates and sensitivity rates, depending on the reference samples that you use in the laboratories. So sometimes it can be high, can be low, depending on how stringent the test is of the new diagnostic. But it's important that subsequently these tests need to be evaluated in real-world settings and in different patients and at-risk groups and in high and low prevalence settings. So on a continuous basis, WHO should update their target product profiles for STIs, POCs. It's quite clear that the target profiles are based on lab-based evaluations, and they really should be based on the results of clinic-based evaluation. Next slide, please. So let's look forward to the rollout of these tests. We've learned quite a few lessons regarding how these tests perform in the field. And so it's important to realize if we're going to use them routinely in the field, the role of the laboratory in support of the rollout has to change by supervising training to create panels of specimens for internal quality control purposes and document and provide feedback to peripheral sites on their performance when they test the QC specimens. We need to pilot the rollout of POC tests in appropriate settings. It's a very important piece of research, and subpopulations as well, and measure the impact of the rollout on the prevalence of disease amongst the most vulnerable. Obviously, a reasonable example is rollout of lateral flow tests for syphilis and HIV, and what is the rate of for instance, HIV infection in babies and also neonatal or congenital syphilis. And then to pilot the utility and acceptance of these POCs to reduce overtreatment in countries where syndromic management is practiced. The problem with syndromic management is generally that overtreatment occurs. One treats, for instance, vaginal discharge with multiple drugs in order to cover gonorrhea, chlamydia, and anaerobic and trichomoniasis infections. These tests would reduce the amount of overtreatment as long as they're accurate enough. And we can't afford to throw out syndromic management because it's the only thing that some countries can do. But we can modify it with the use of POCs. Last slide, please. Next slide, please. So, like everybody else, it's acknowledgements. First of all, the many thousands of subjects, the staff who participate in country laboratories and sites, the staff of the diagnostic companies that participated, the many authors who've contributed to the writing of manuscripts, and of course, the reviewers who have contributed to making the BMC supplement a reality. The PRoSPeRo editorial board and editorial staff at BMC as well, and in particular, Igor, Carol Blondil, Natalie Moret, and staff at WHO, HRP for their ongoing support and staff. And I say that on behalf of David and myself. Now, the one last thing, and you can go to the next slide, please. Go to the next slide. The one thing we can say is, unfortunately, this supplement is taking has taken a long time to come to fruition. There've been a couple of very important reasons. First of all, the COVID epidemic that people have mentioned, which resulted in staff being diverted to other clinics, other priorities, namely COVID. Secondly, many of you will know that I've been indisposed for something like 11 months as a result of really poor care and subsequent real problems following surgery, and David stepped in to take up the mantle, and I really appreciate it so much, and I appreciate the support I had from everybody else. So thank you very much.
Ron, thank you very much indeed for your presentation, and special thanks from WHO and all PRoSPeRo network and all partners for your outstanding contribution, not only to this project, but to the overall work of the STI expert community in the field of STI control and prevention. This contribution is outstanding, and we are very pleased to see you back after a very long period of absence, and we are very glad to see that you are getting better. And special thanks to David, who really provided fantastic, outstanding support through several months, more than a year, for supporting the peer review of the articles, and finally for publishing these articles in the supplement BMC. Thanks a lot. So we now done with the presentation. We have just few minutes, 5 minutes, something like that, for the questions and answers. So dear colleagues, dear attendees, if you have any questions to the speakers, if you need any clarification, this is the time. Please use the function questions and answers. I see just the comments. Thank you very much, Susan. for supporting the comments provided by Ron about the needs of clinic-based evaluation and other comments that Ron provided. I see. The colleagues, please, if you have any other questions, write it down in open in the Q&A function of the Zoom. If you have, I think that you all have access to this function. Please. Unfortunately, we do not have a function to see your questions if you raise the hand. This is the by default in this Zoom platform, but questions in writing are fully accepted, and we will be very pleased to see your questions if you have any. Thank you very much again. Congratulations to Ron and David. Thank you. So, colleagues, if you do not have any questions, any comments, probably, James, we can close. What do you think? Or...
Yes, I think we can close.
Yeah. Thank you very much indeed. Once again, on behalf of SRH, HRP, and the HHS department of WHO and WHO in general, we would like to thank all participants, contributors to this project. I would like also to extend special gratitude to WHO Collaborating Center in Australia, National Reference Laboratory, supported us through the development and provision QC and QA materials for the arms of the study aimed to evaluate molecular-based tests. And I would like also to extend our gratitude to the government of Canada, provided financial support for moving forward the work on the publication supplement. And special thanks to all panelists of today's webinar for the fantastic presentations. Thank you very much to all attendees finding the time to join us today and for your attention to this topic. Again, many thanks to guest editors, David Lewis and Ron Ballard. And I would like to extend my gratitude to James Chiari, co-chair of this webinar, and also very key participant and supporter of these projects from the beginning. So I would like just to thank you again and wish you all the best. We hope that we will have a lot of other opportunities for collaboration, and we are looking forward to continuing our collaboration. As I mentioned at the beginning, many articles, most of the articles now made available online, and you can access it via QR code and link. But as I said, we expect a few additional articles to be published in the coming month, hopefully by the mid of 2024, and we will keep you updated on this, on the progress in this regard. And I would like also probably to thank all technical colleagues from WHO who help us with the setting up the webinar, and our communication team, Natalie Bailey and others who support us with preparation for the webinar. James, did I forget someone, please?
No, I think, Igor, you covered everyone. It's been an excellent job. I think this study has involved so many collaborators, and maybe just to apologize ahead in case anybody was missed. We really do appreciate the input. To get this study done really takes a lot of effort. But as you can see, the results are really something that we'll need to take into account as we move this field of the point of care testing forward. Thank you everyone also for attending. The participation in terms of numbers in the webinar was great. We really do appreciate that there's a lot of interest and so many of you spent your time to attend the webinar. Thank you and bye-bye.